Recording.
Welcome to orientation. I'm sorry I can't be with you today, so I'm going to share this presentation via Zoom. This is Guy Moyer who's presenting. I am the clinical nurse educator for the emergency department for ambulatory care, as well as cardiac rehab. I've also been the nurse educator on 5 South, 5 West, and I've covered 3 South. So I'm pretty well versed in the hospital and the different units. This presentation is actually created by your sepsis coordinators, Ann Carter, who's an APN that is in charge of the program, sepsis program here at Riverview Medical Center, as well as Shannon Wanless. She is one of the APNs that will come to your unit when you do activate the code sepsis. So the objectives of this presentation to describe the elements of sepsis, severe sepsis, and septic shock, identify SIRS criteria, determine the elements of organ dysfunction, identify components of the 3 and 6 hour bundles, use of the sepsis screening tool to screen patients for sepsis, identify the required documentation for compliance, for survey readiness, as well as CMS and Joint Commission, as well as verbalize the elements of post-sepsis syndromes, which many of our septic patients will experience post-discharge. So what is a core measure? National standards of care and treatment process for common conditions. Proven to reduce complications and lead to better patient outcomes when we are compliant with these core measures. Core measure compliance shows how often a hospital provides each recommended treatment for certain medical conditions. And they're also monitored on a monthly basis by the federal government and CMS. And a lot of them are tied to reimbursement for Medicaid and Medicare. So what is sepsis? Sepsis is the body's overwhelming and life-threatening response to infection that can lead to tissue damage, organ dysfunction, as well as death. There are 4 types of infection that are most often associated with sepsis, and they are lung infections, urinary tract infections, skin infections, as well as gut infections. So you see a lot of these different infections are part of the admission diagnosis when the patient is admitted to the hospital. So the CDC found that more than 90% of adults and 70% of children who develop sepsis had a health condition that may put them at risk. Sepsis occurs most often in people who are 65 years or older, which is our geriatric population, as well as children younger than 1 year of age. It also affects commonly people with weakened immune systems and those who have chronic medical conditions such as diabetes and COPD. And as you can tell by being nurses, that the patients that we take care of in the hospital have multiple comorbidities and things that are wrong with them rather than just one particular diagnosis that they're being treated for. So there is a new and improved definition by CMS for sepsis, and they've divided this into 3 levels of sepsis. Early sepsis, which is what we want to try and identify from the get-go to prevent them from getting to the next phases, such as severe sepsis, and the worst phase of sepsis, which would be septic shock, which oftentimes leads to mortality. So why the change? Medicare costs for sepsis admissions and skilled nursing care exceed $41.5 billion annually, Medicare's most costly healthcare condition. On the average, approximately 30% of patients diagnosed with severe sepsis do not survive. Sepsis infection is one of the leading causes of death in the United States hospitals, and up to 50% of survivors suffer from post-sepsis syndrome. Sepsis is the #1 cause of hospital readmissions, costing more than $3.5 billion each year. So early detection is the surest hope for survival and limiting disability for those that do survive sepsis. So this is the sepsis train. So part of this presentation is get on the sepsis train, stay on track. Early identification is the key. So early sepsis we're going to talk about first. So early sepsis is met when there are 2 criteria. The first is documentation of a source. That's any suspected or confirmed infection. So if they come in with the emergency room with a definite diagnosis of something like pneumonia, that will be considered a diagnosis, or if they're admitted with a diagnosis of something infectious, or a rule out pneumonia, or rule out a urinary tract infection. And in addition to that, you also need 2 or more manifestations of a systemic infection according to the systemic inflammatory response syndrome. That's our SIRS criteria, which we'll talk about a little bit. So source of any infection. There may be reference to possible infection, suspect infection, rule out infection, or similar documentation in the medical record by the physician or the advanced practice nurse or the physician's assistant. So during daily screening, clinical signs of infection should be used. Suspect sepsis infection is the engine. It's the beginning part of your screening process. So that's the engine of the train. So what's a quick way to identify a suspected or an actual infection? Antibiotics. So if a person is placed on antibiotics, that's a key to identifying that the patient actually has a source. So the physician orders antibiotics if they suspect or they confirm a bacterial infection. The time that they actually put the order in is the source time. And the order also identifies the suspected source of infection. And we talked about that a little bit earlier. Is it the gut? Is it the lungs? So your SIRS criteria. So you need to meet 2 of them. So our first criteria is a temperature that is less than 96.8 degrees or greater than 100.9 degrees. If they have an elevated heart rate, that's greater than 90. If their respiratory rate is greater than 20, you actually have to count their respiratory rate. A lot of people just put 20 in as a common practice, but you really should be counting the respiratory rate of the patient. And then you need to start looking at your lab values. If they have a white count that's less than 4,000 or greater than 12,000, if they have bands in their CBC greater than 10, that's also another sign. And as you know, if there's an abnormal lab value, the lab will call you to notify you and will also change color and epic when you're reviewing your results to let you know that it's abnormal and not within normal limits. So on all of our units, we do have a screening tool for you to utilize if you think a patient is septic. So the 2 first things that we're going to look at is there a new or suspected or confirmed infection that could happen at any time from evaluation in the emergency department, as well as when the patient is actually admitted to your unit. And in addition to that, there are also your 2 SIRS criteria. And when you're looking at your SIRS criteria, you want to identify what time did these 2 criteria occur in addition to this source of infection being identified. And that is early sepsis. And that's what we're going to try and recognize right off the bat to prevent our patients from progressing into a more terminal state. So if this does happen and you have this diagnosis and you get your vital signs and realize that they are abnormal and you have some lab values that are abnormal, if there's at least 2 along with that identified infection, you want to notify the APNs and call a sepsis alert. So during the daytime, you can call a sepsis alert and contact the APNs, Ann Carter or Shannon Wanless, and on the off-shift hours, you would identify your sepsis symptoms, and then you would call the hospitalist to come and evaluate the patient. So then we're moving on to our next phase. If we didn't identify early sepsis, we're moving on to severe sepsis, and that's the next piece of the train. So in order to establish the presence of severe sepsis, there are 3 clinical criteria. Documentation of a suspected infection, documentation indicating that the patient is taking antibiotics for an infection. Infection on arrival to the ED may also be used as a suspected infection. 2 or more manifestations of your SIRS criteria, in addition to 1 organ dysfunction. So when you're evaluating these things, all 3 clinical criteria must be met within 6 hours of each other. And it starts from arrival to the hospital. So if they start out into the emergency department and they have a suspected infection and are on antibiotics, as the nurse that's receiving the patient on your unit, you need to track their additional vital signs as well as their lab values to see if they're falling into this severe sepsis state. So organ dysfunction, one of the following, not due to something else, is considered organ dysfunction. So if they have a systolic blood pressure that is less than 90, or a mean arterial pressure that is less than 65, or a systolic blood pressure that has decreased greater than 40 points from baseline, meaning if they came into the emergency room and their systolic blood pressure was 140, and then they reach your unit and now it's 90/60, that's a 40 points from baseline drop. The mean arterial pressure is more something that they identify in critical care areas where they're monitoring this, but also when you're taking your vital signs, say the PCT reports to you that systolic blood pressure is less than 90. That should be an alert to start thinking about sepsis. In terms of lab values, if they have a creatinine that's greater than 2.0, or if they have urinary output that's less than 0.5 mLs per kilogram per hour for 2 hours, so say the patient has a Foley catheter and they void in the collection bag and you see that it's a very small amount, that should be a heads up for you. These two criteria, though, can't be utilized in patients that are on dialysis because we know that the patient might have an abnormal creatinine and they may not have any urinary output on their own at all. We're also looking at bilirubin greater than 2, a platelet count that's less than 100,000, an INR that's greater than 1.5, or a PTT that's greater than 60 seconds. And these are for patients that aren't on anticoagulants. If they are, there's a variation because they have different lab values based on what's therapeutic. And also if a patient is in acute respiratory failure with the need of new mechanical ventilation, if the person on your unit goes bad and has to be put on BiPAP or CPAP, or if they end up being intubated, that is a sign of respiratory failure because your lungs are failing and can't maintain oxygenation without some type of support. So for the devices, that's going to be easily recognized by you because you'll probably call a rapid response. But in terms of lab values, we rely heavily on the lab to call us and alert us that there is an abnormal lab value. And it's really our responsibility to make sure that we follow the patient's lab values. And if there is anything abnormal and we do suspect sepsis, that we do notify a sepsis alert. And we also notify the physician or the hospitalist that's caring for the patient. Also, in terms of lab values, you're going to be looking at your lactate levels. And if you get a lactate level that's greater than 2, that's something to alert you that there's some type of organ dysfunction that's occurring. So going back to your screening tool, you're going to look at your different categories and see, does this person fall into that criteria? Is there a new suspected or confirmed infection? Maybe something was identified when there was a consult and there was a new diagnosis that was added to the patient's primary diagnosis. Also, you want to look and see if you have those 2 SIRS criteria, what time those criteria occurred, and then you want to look and see if there's any organ dysfunction. And that's based on the things that we just talked about a little bit in the previous slide. So if they do, you say, do these occur within 6 hours of each other? If the answer is no, then it is a negative screening. If the answer is yes, then they meet severe sepsis criteria. And then you should begin your 3-hour bundle. You want to notify the APNs by calling a sepsis alert or contacting during the day Ann Carter or Shannon Wanless, and their extensions are on the screening tools that are provided on your unit. So when you're starting your 3-hour bundle, within this 3 hours for severe sepsis criteria, presenting at time 0, you want to make sure that you draw your lactate, your lactic acid. That's gray on ice, no tourniquet. You want to make sure you draw your blood cultures, and you also want to make sure that you start antibiotics. For the most part, if the sepsis is identified in the emergency room, all of these things will be done prior to them arriving to your unit. But if you have a rapid response on your unit, it might be your responsibility to be the one that's drawing these lab values before they're transferred to a higher level of care like the ICU. If you are unable to draw any labs, you need to document that in the medical record that an attempt was made, so that when they're abstracting the charts for data and sepsis compliance, that it's clearly stated that you were unable to draw the labs, because sometimes these patients are very clamped down and their pressure is low, they have poor IV access, so you can't really get the labs that you need at the time that it's identified. So every hour delay in antibiotics after the onset of organ dysfunction or shock may lead to a 3 to 7% increase in the odds of a poor outcome. So you want to identify early and you want to start that treatment bundle as soon as you can. So here's a question for you. Does a lactic acid result greater than 2.0 always mean the patient is septic? And the answer to that, no. It means there's some marked tissue hypoperfusion. And some of the causes of that include sepsis, local tissue hypoxia, if a patient is actively having seizures, if they're hypothermic and they're shivering, if they're in respiratory failure, if they have heart failure, status post-cardiac arrest, where there was some CPR going on, some heavy duty manipulation to the muscle and the tissues from the compressions. If there's any type of impairment of cellular metabolism, such as a patient in diabetic ketoacidosis, if they have any type of malignancy or cancer, and also patients with chronic alcoholism can also have an elevated lactic acid. So just because the lactic acid is greater than 2, it doesn't always mean the patient is septic. There may be something else that's causing that elevated lactic acid. So then we're looking at our 6-hour bundle. So you have your 3-hour bundle and you also have a 6-hour bundle. Your 6-hour bundle must be started within 6 hours of presentation time. So if a repeat lactic acid was drawn on the patient and it was greater than 2, that meets the criteria for your 6-hour bundle. If the patient has 2 or more blood pressures, or systolic blood pressures rather, that are less than 90, you have to give a fluid bolus. If shock is present, the physician must document a focused exam, a sepsis vascular assessment in the patient's medical record. And this must be done after the fluids have been started. So if they fall into this criteria within a 6-hour time period from admission, then the hospitalist or whoever is caring for the patient needs to document in the medical record. And sometimes this is a fallout. So as a nurse, you can remind the physician when they're coming up to evaluate the patient and put the orders for sepsis, just to remind them to make sure that they do fill out their vascular assessment. So on your screening tool, it's two-sided. The second page of the screening tool gets into that severe sepsis mode. And severe sepsis is your 2 SIRS criteria, an organ dysfunction, and a suspected infection. That's your severe sepsis times 0. So you enter the time in that. You want to make sure everything was done within your 3-hour bundle. And like I said, if they come from the ED and they're septic, most of this is already going to be done. So we're going to draw a rainbow on the patient. We're going to order blood cultures on the patient and send them. Make sure that you document that they were sent before you start your antibiotics on that patient. And you also want to draw lactic acid. The goal is to have the antibiotics started within 1 hour time of identification of sepsis. So once you meet the criteria of your 3-hour bundle and that's completed, the 6-hour bundle needs all these things completed within time from the identification of time 0. That's, you got to make sure that your lactic acid was drawn initially and that you did a repeat lactic acid on the patient. If there are 2 systolic blood pressures that are less than 90 within 6 hours of time 0, fluids must be given, and need an order specifically to say that crystalloid IV fluids, normal saline or lactated ringers, must be given at 30 mLs per kilogram. The order must include the time to infuse and the total volume. So that needs to be calculated based on the patient's actual weight. The physician should put in an order for exactly how much fluids need to go in. And when you're calculating your fluids, your IV antibiotics that you hang are also going to count as part of your fluids if you put them in your I&O and you tally all that fluid volume. So you want to document the time the fluids are completed in the medical record. So make sure that you stop your fluid infusions and that there's a total value that's calculated by starting your next and finishing your next, as well as your antibiotics. So you have an accurate I&O. What's important in that 6-hour bundle, in addition to having the fluids documented that they were completed, is to record 2 blood pressures in the first hour following the conclusions of the total volume. Because what you're looking for is to see that there's an improvement, and that would be gauged by, is there an increase in the patient's systolic blood pressure? Because if it's still less than 90 after you give the weight-specific calculated bolus of fluids, then that patient's already moved into the septic shock phase of sepsis, and you might need something like a vasopressin agent to correct that patient's blood pressure. And you're not really going to manage that patient on your med surg or telemetry unit. That patient needs a higher level of care oftentimes, so they might have to end up in the ICU on a titratable medication. So once you've reached that septic shock phase, the train is already going off the track, and it's hard to go back once you're in this condition. So then we move into our septic shock phase. So septic shock is severe sepsis plus an lactic acid that is greater or equal to 4, regardless of the systolic blood pressure, and or if the systolic blood pressure is less than 90, even after the fluid boluses have infused. So if the systolic blood pressure is less than 90, then you're moving into that shock phase. So your 3-hour bundle for septic shock is also similar to that one for severe sepsis. Make sure that you draw your lactic acid, you draw your blood cultures, you hang your antibiotics. And most likely you're going to call a rapid response on this patient because they're hypotensive and symptomatic. If the lactic acid is 4 or greater, or the systolic blood pressure is less than 90, times 2, so you check it twice within the hour after you got the fluids in there, then they're in that shock phase. So crystalloid fluid administration. So initiation of crystalloid fluids prior, at the time of, or after the presentation of initial hypotension, which you talked about, that should take the blood pressure times 2 and the systolic is less than 90. They've got that elevated lactic acid greater than 4. And then the physician, APN or PA, documents septic shock in that patient's chart. So fluids given within 6 hours prior to or within the 6 hours following any of the above are acceptable to count towards that total fluid volume of 30 mLs per kilogram. If a patient has congestive heart failure or dialysis by history, it is not a contraindication to fluids. So you might want to use that, physician might want to use the ideal body weight for calculation. They might give you an order to infuse it slower or greater than 125 mLs per hour. And they also need to have some kind of exclusion note documented. So if they choose not to follow the protocol because of the patient's history, then they need to make sure that they document in their notes what the exclusion is and what the rate is and why they chose to do that. So for nursing responsibilities, we talked about this a little bit earlier. You want to document the time the fluids were started. You want to document the time the fluids ended to confirm that the patient received that full 30 mLs per kilogram. And you also want to document 2 blood pressures after the fluids are finished. So within that hour. So just think about it. As soon as the bag is infused, it might not necessarily be given to the patient in the emergency room. If there's a bed availability, perhaps that patient is still getting fluids while they're coming up to your unit. So you have to stop the fluids. And after you stop the fluids, the complete bolus is in. You want to take their blood pressure immediately afterwards. And then within that hour time period, after the fluids have infused, you want to take it again to see if the systolic blood pressure is now greater than 90. So again, this is just reviewing the second page of your screening tool. What the septic shock criteria is, that's your severe sepsis plus your lactic acid equal or greater than 4 for your repeat. Hypotension with a systolic blood pressure reading of less than 90 within 1 hour after the conclusion of your total fluids. And that's your septic shock times 0. So we reviewed our 3-hour bundle before, as well as our 6-hour bundle. Just very important to ingrain it into your brain to make sure that you get those 2 readings of your systolic blood pressure post-fluid infusion. So your sepsis screening tool is something that you should use on a daily basis if you have patients that you think may be sepsis. You should be discussing a possible sepsis criteria in your handoff and your IPASS, identifying the patient's vital signs and labs and things to look for to see if your patient might be meeting sepsis criteria. So tips for handoff. So if you're talking to the physician and you think your patient might be septic, you can just voice your concern. You say, I'm concerned that the patient might be septic, and then they can review the lab values, the patient's vital signs, and the different criteria to see if they meet that criteria. At your change of shift or unit change, like I said before, in your IPASS, when you're giving your handoff, identify any possible or potential infections that the patient has in their diagnosis or that have been identified. You want to speak to any SIRS criteria or organ dysfunctions, and that's looking at your labs. If they have lactic acid drawn, you want to look and see what it was. If the second one was more elevated, if there's any change in it. You want to make sure that there was fluid documentation, so make sure you do your I/NOs at the end of your shift. And you also want to look at vital signs and trends, especially your blood pressure, to see is there a systolic drop greater than 40 from what their baseline is, and is their systolic blood pressure less than 90. So disease-specific certification, we are a sepsis hospital, and we do have Joint Commission surveyors that do come to make sure that we are following our protocols. So we did have our last visit in September of 2021, and they are due to come back to Joint Commission in 2023. So we are going to be on the calendar. It could happen anytime. The surveyors can be on site. So the different areas of focus, there's 5 main areas that they like to focus on where they're doing chart reviews and they're speaking with the staff related to sepsis. They want to know that the patient got antibiotics. They want to see that the physician did order fluid resuscitation and that the vital signs were documented according to our protocol. They want to make sure that the physicians in the emergency room, as well as in-house the hospitalists, the intensivists, are using the sepsis order set for patients that are in that criteria. They also want to make sure that patient education has been provided. And they want to know that the patient has a perception of care related to sepsis. So they do this by doing tracers. They'll find a medical record number of someone who came to the hospital with some type of a diagnosis in the emergency room. They met sepsis criteria. They ended up being admitted to the hospital, and then they ended up being either admitted to ICU, admitted to one of the floors, through discharge or transfer out. So they might come to your unit and ask you to open up a patient's chart and go through the different components of sepsis documentation. What are you looking for? What lab tests do you draw on the patient? How do you learn about your criteria? Are you aware of what the sepsis bundle are? Can you show me the documentation in your care plan related to sepsis? Can you show me that you provided education to the patient in your documentation in EPIC? As well as, did you give the patient discharge education on sepsis? And they will ask you to identify it and show you where to find it. So they're definitely going to check for education, plan of care, and discharge education. So you want to make sure that upon admission to the hospital that you start that education as well as start putting things into the discharge education for that patient so that they have a whole packet of things that they can follow when they are discharged to home. Anyone on an antibiotic is at risk for sepsis and should have all 3 completed in nursing documentation. So any diagnosis where a patient has some type of bacterial infection and they are on an antibiotic, you need to include sepsis education, sepsis in your plan of care, as well as sepsis in your discharge education. So your documentation for education, it has to be once a shift. Why are the patients getting the antibiotics? You're going to discuss with them and put it in their education, whatever related illness that they have. You want to give them general education on what sepsis is, and you also want to go over the signs and symptoms of sepsis so that they can recognize these signs and symptoms when they go home. There are handouts on your unit that you can give, and there's also things that you can add into the EPIC chart so that when you print out your discharge instructions and your AVS, all of those things will be printed out and given to the patient prior to discharge from the hospital. I'm going to show you a little video. This is life after sepsis. So, post-sepsis syndrome must be recognized by doctors and other healthcare professionals who care for sepsis survivors so the patients can be directed to the proper resources. And some of these resources might include referrals for emotional support, psychosocial, psychological support, counseling, cognitive behavioral therapy, or neuropsychiatric assessment, as well as physical support, such as physical therapy or neuro rehab. So most of you have case managers that work on your units that can help to align these resources for the patients and make sure that these things are in place prior to being discharged from the hospital, because it is a very common thing. And we want to prevent those readmissions to the hospital, not only by identifying early sepsis, but also by providing the resources for those patients who have survived their hospitalization with the diagnosis of sepsis and are going back out into the community or are going into some rehab facilities prior to going back into the community. So for our disease-specific certification, we're going again to review a little bit about that sepsis documentation. So make sure that you do have plan of care documented on that patient related to sepsis. Identify those things specifically related to your patient. So if it's a problem that has to do with their lungs, make sure that you have something that has to do specifically to that disease-specific diagnosis. So you might want to assess their respiratory status, their skin condition. You want to keep assessing for your signs of septic shocks. That's your hypotension, and looking at your lab values and your lactic acid. And you don't want all of your care plans or plan of cares to be exactly the same on all your patients. What the Joint Commission surveyors specifically are looking for is that you are including something in that plan of care that is specific to that patient, and that you're not just checking off boxes on all your patients with similar diagnosis. And if something's resolved, for instance, if you have the patient on mini-neb treatments, duo-neb treatments, and you taught the patients about that, and it's in your plan of care, and the patient's no longer receiving those treatments, you need to complete that and change your plan of care to reflect whatever's going on with the patient in their current state. So we're looking a little bit into EPIC. This is some screenshots that Ann has provided for sepsis documentation. So on admission, you want to go into your education category and you want to select that sepsis adult admission. And you can see on the right-hand side, there's a little bit of different categories that are related to some things that the patient maybe needs a little education on and should be involved, not only the patient, but their family members as well. So there's several categories that you can select, but the first thing that you should probably select in all patients with sepsis, and that's anybody that's on an antibiotic, is that introduction to sepsis. So the education starts on admission. Oops, skipped a screen. So your discharge education, when you're going in, you want to choose your general DC education. Inpatient can be used by you as a reference. If you select reference only, I'll show you on the next screen, it's just a list of references. So to clarify that a little bit. So when you're under your sepsis, under discharge instructions, if you look on this left-hand side, you'll see general information, sepsis details, information in English, information in Spanish, and also this reference in English. This reference in English you don't want to give to the patient because it's just going to be a list of references of resources that the patient can like look up. So select sepsis general information in English, and then you can pick either Spanish or you can pick English for inpatient care that the patient received while they were in the hospital as well. And this is going to be printed out with your AVS upon discharge. You hit accept, and that's going to be part of your discharge education. This is what I was talking about that you don't want to select. If you're going under your categories and you just select sepsis references, this is exactly what it's going to be. Just a list of references of different things that they got the information for the discharge instructions and the education from this set of resources. So that's not really useful to the patient. So you got to keep it in your mind at all times when you're taking care of your patients. Could it be sepsis? It's a simple question, but it could save the patient's life. So let's go over a couple of case studies here. So our first case study, we have a 30-year-old male presents to the ED from a long-term care facility. He's got a history of anoxic brain injury. He has a trach as well as a PEG. He has recurrent urinary tract infections, and the patient is in a persistent vegetated state. At 14:27 p.m., some labs were done on the patient. The urine was sent, and it's positive for WBC, some white blood cell in the urine, and UTI, urinary tract infection, is considered as the diagnosis for this patient. The patient initially came in just with a complaint of a fever. You take the patient's vital signs at 1:15. When they came in, the heart rate was 135. The blood pressure was 102/72. Respiratory rate was 20, and the patient had a temperature of 102.2. Put a little pulse ox on the finger. The SpO2 is 95%, and the patient is on a trach, 8%, and there's a mask with oxygenation delivery mode. There is no documentation of the patient's weight. Is there a possible infection based on this history and the criteria that are presented? Any STIRS criteria that you can identify? So let's look and see what we can identify. So possible diagnosis here, urinary tract infection. We have an elevated heart rate. It's 135. In addition, the patient is febrile, 102.2. So what kind of sepsis have we identified? We're getting on the train here. So we order some blood cultures at 13:12. The lab calls you with the abnormal lab results. Weight count of 14.8, platelet count of 235, creatinine less than 0.41, bilirubin is 0.7, and lactic acid is 2.9. Is there any organ dysfunction that's being identified at this point based on these lab values? So you know they're abnormal because you've reviewed your labs, and the lab has also called you to let you know there's some abnormal lab results, so you can notify the physician. So lactic acid is greater than 2, so that's 2.9. What kind of sepsis is this when there's organ dysfunction identified? Severe sepsis, right? We have our urinary tract infection as our diagnosis, our 2 STIRS criteria, which is your elevated heart rate and your elevated temperature. And in addition, there's a sign of organ dysfunction because your lactic acid is greater than 2. It's 2.9. What else should be done as per your sepsis core measures in the sheet that I handed out earlier? So you want to start your antibiotics and you want to repeat your lactic acid. So that's your 3-hour bundle in use, right? You drew your labs, you make sure that you start your antibiotics within 1 hour after you send your blood cultures and your urine cultures or whatever else you're going to send a culture on. So sepsis was documented in the medical record at 14:27 p.m. The patient was started on 3 different antibiotics, or 4 different in this case. Gentamicin, imipenem, cilastatin, vancomycin were ordered at 14:27 p.m. At 14:56, they did a repeat lactic acid on the patient. They say the repeat should be done within a 4-hour time period. It's better to do it sooner than that. The patient did receive a fluid bolus, 2,000 mLs of 0.9 normal saline, and that was weight-based on 30 mLs per kilogram. The physician did order it correctly. And after 5 days, the patient was discharged back to this long-term care facility. Has everything been done for this patient? It has, right? We identified the sepsis, we treated the sepsis, and the patient had a positive outcome and was discharged back to their facility. We followed all of our sepsis protocol steps. So now we have case number 2. A 60-year-old male presented to the ED from home. History of congestive heart failure, aortic valve replacement × 2, AFib, patient is on Coumadin, has a history of endocarditis as well as hypertension. The chief complaint on presentation to the emergency department was difficulty breathing for 3 weeks. So on day 1 in the emergency room, when they came in at 8:10 in the morning, they had a heart rate of 70, a blood pressure of 121/58, a respiratory rate of 18, and they were satting 97% on room air. They actually did have a weight documented, 58.9 kilograms. Not all the stretchers in the emergency room have scales on them. Those patients that come in ambulatory or by wheelchair get weighed out in triage. If they're put on a weighted scale when they come in from EMS, they can have a weight that's taken. If they're not, then it might be an estimated weight. So it's your responsibility once a patient gets to the floor to make sure you weigh that patient to get the most accurate weight if they did not get that weight in the emergency room, right? Because our blue bolus is based on the actual patient's weight. So in this case here, are there any SIRS criteria? And is there anything that's missing on this patient? So let's look and see. What's missing? The temperature. There's no temperature. So you're not going to know if you met the SIRS criteria if they didn't actually do a full set of vital signs. So they did a chest x-ray on the patient, showed some bibasilar infiltrates and effusions and some mild congestion. The labs values that came back, a creatinine of 1.32, a bilirubin of 4.2, a white blood cell count of 13.4, a platelet count of 166, and an INR of 26.37. So we're not advanced practitioners and we're not physicians, so we're not asking you to memorize all the lab values, but you need to do your chart review so that you can look and see if there's anything identified, and the lab will usually call you with any abnormal lab result. So, is there an organ dysfunction based on these lab values? So we'll just point some out. So your bilirubin is elevated. Your INR is 26.37. You can't really use that as an abnormal lab value because your person's on Coumadin. So that's something that you have to remember. Should anything else have been done on this patient and have been ordered? Lactic acid should have been ordered on this patient because you're thinking maybe the patient's septic, right? In addition to that, blood cultures, because we don't want to hang antibiotics on a patient for an infection if we didn't draw our cultures, sputum cultures, blood cultures, urine culture, based on whatever the person's suspected source of infection is. And once we've done these things, the lactic acid, all our labs are done, our blood cultures were sent, then the physician responsibility is to order antibiotics on this patient for that infection. So this patient was given 40 milligrams of IV Lasix and was admitted to the telemetry floor for congestive heart failure as a diagnosis. No temperature was documented. They didn't send a lactic acid in the ED because the ED physician did not use the sepsis bundle or sepsis order protocol. Blood cultures were not ordered and antibiotics were not ordered. So the patient came in through the ED, was admitted, didn't have these things done, and you as the floor nurse are getting handoff on this patient. So day 2 of the admission to the hospital, AM labs were drawn. The creatinine is now 2.35. The bilirubin is 5.4. They have a white count of 21, a platelet count of 84, one band in their CBC. The INR is 20. Additional diagnosis was added to the patient's admission diagnosis as pneumonia. So pneumonia was documented in the medical record. The blood pressure and vital signs were taken at 9:48 a.m. on day 2. The blood pressure is now 103/50. The heart rate is 60. The respiratory rate is 24. Temperature of 97.4. And a lactic acid was drawn, and it is now 10.2. So we're looking for our sepsis criteria on this patient. So what do we got? We have a new diagnosis of pneumonia, so that's a source of infection. We have an elevated respiratory rate of 24, right? The patient's afebrile, but they have an elevated respiratory rate, and they've got a weight count of 21 and a lot of different abnormal lab values, right? Their creatinine is elevated, so that shows some organ failure going on with their kidneys. Their bilirubin is elevated as well, liver involvement. Platelet count is low, 84. Their INR was 27 or 29 on the last slide, and it's now 20. And their lactic acid is much greater than 2. It's 10.2. So what do we count as a presentation time when all of these things come together to meet that criteria? So at 9:48, with only one abnormality in the patient's vital signs, that's their respiratory rate. That's the presentation time for the worst kind of shock, which is your septic shock. So the train's already off the track. We're a little late to the game. We didn't identify that sepsis early on, or early sepsis when the patient was first admitted, and we didn't do all the necessary testing to identify it. So a sepsis alert was actually called on the floor. Blood cultures, lactic acid were reordered. The patient did get a fluid bolus based on 30 mLs per kilogram with our actual weight that we had on that patient. It was completed. The antibiotics were ordered and completed, and they were ordered and given within the first 1 hour. ID was consulted. They did a second repeat lactic acid within that first 3-hour time period at 11:07, and the lactic acid was declining. It was 8.4. So what 3 things should be done next as per sepsis core measures on this patient? So make sure that you document the time that all of the fluid has infused. Make sure you document 2 blood pressures within that hour's time after you completed the fluids. And once the patient is being evaluated by ID or the hospitalist or the attending, just try and remind them to do the sepsis vascular reassessment. You should probably already know that if it's during the day shift, you want to call that sepsis alert to get the APNs notified so that they can actually track that patient in real time. So the outcome for this patient, the IV fluid documentation was completed. A focused exam was completed. The patient was transferred to the ICU. The patient stayed in the hospital as a result of septic shock from the 3rd of December to the 15th before they were discharged to home. So if we would have identified and did the proper testing early on, maybe this patient could have avoided this long admission and maybe have avoided the post-sepsis syndrome that they may end up with as a result. So what are your take-home messages? Suspect sepsis if your patient has an infection. If they're on an antibiotic, then they have an infection. So then you want to start looking for your SIRS criteria, and you want to start your education and your discharge education related to sepsis. Time matters. When in doubt, if you're not really sure, call a sepsis alert. That's going to get that APN in to evaluate the results and evaluate the condition. Or on the off shift, it's going to get the hospitals involved in the patient's care to see if the patient meets any criteria that could end up with a diagnosis of sepsis. You want to try and be compliant with your 3-hour bundle and your 6-hour bundle. You do have your sepsis checklist on the unit. It's just a worksheet to help you work through the things that you need within that 3-hour bundle as well as that 6-hour bundle, with an emphasis on ordering the cultures and the lactic acid and starting those antibiotics within 1 hour. And if you're unable to draw the labs, make sure that you document that an attempt was made. Put it in the chart in your nurse's notes that it can be identified by the abstractors when they're looking at the data. Document when the fluids are completed, and make sure you check your blood pressure 2 times in that first hour after the fluids have been completed. And just be mindful, the fluids may not have all been completed if they're coming in from the emergency room. So when they get to you, you want to make sure that you have in your I's and O's the total amount of fluid volume that went in, and that's including your IV piggyback antibiotics. And if you suspect sepsis, when you call the provider, say, I'm concerned about sepsis, and then they're probably just going to go over the criteria or why you think that patient has sepsis. And then consider your post-sepsis syndrome when you're doing your discharge education. I know there's some handouts that you can print out as part of your AVS. And there's some handouts that are on your unit that you can give to your patients related to septic care or sepsis identification at home. Thank you for listening to my presentation, and have a good day.